Hi everyone, good morning. My name is Gemma Mccall and I'm CEO and co-founder of Culture Shift. For those who are new to a Culture Shift webinar and our online events and us as an organisation, just want to give a little brief introduction about who we are. We're a Tech for Good organisation who believe in a future work of world and study that is safe, happy and supportive for everyone, everywhere. We do this mainly by using our software and service to empower organisations to tackle harassment, bullying and discrimination of all kinds and allow leaders to activate positive change within their organisations and maintain the culture that they want. Our software currently helps over 85 organisations and we give the opportunity for over 1.7 million people to speak up through our software, which helps organisations transform the way they're listening to their people and help foster a sense of belonging, and that sense of belonging that we all desire and actively seek when we're at work. And we also help to identify, track and prevent any incidents that people may want to take a proactive approach to tackling. We've recently partnered with some NHS organisations, and so today we really wanted to use our platform and our knowledge to help share best practice, insight and advice to NHS change makers across the UK. I'm going to introduce our panellists now, and I'm absolutely delighted to be joined today by Juliana Ansah, Paul Deemer, Karen Pearce and Dr. Leanne Armitage. Juliana is the head of EDI at East London NHS Trust and the director of Black Leaders CIC, which is a community interest company empowering Black healthcare leaders to increase career prospects and reduce inequalities in the UK. She has worked in various strategic roles, including population health and financial strategy manager at North East London NHS Clinical Commissioning Group, improvement and change management specialist at one of the largest NHS trusts in England, and operational manager at the Office for National Statistics during the 2021 census. Women in the NHS e-magazine recently published Juliana's first op-ed about the impact of discrimination experienced by NHS staff. She has a really wide range of experience in managing large-scale projects with a really keen interest in reducing health inequalities nationally. Good morning, Juliana.
Thank you. Good morning. Good morning, everyone.
I'm now going to introduce Paul Deemer. Paul has nearly 20 years of experience working at NHS employers. Through his work, he supports employers to go beyond legislation and make the NHS an exemplar in terms of equality, diversity and human rights in the workplace. He is truly committed to supporting and promoting good human resource practice in an ethical and values-based way. Hi, Paul.
Hi, Gemma. Thanks very much for that introduction. You've just taken 10 years off my life, you know, so I've been doing this stuff for probably 30 years, so it's great. Thank you.
Sorry about that. I'm going to come to Karen next. Karen is the head of Equality, Diversity, Inclusion People at the Newcastle upon Tyne Hospital's NHS Foundation Trust, providing leadership and expertise relating to equality, diversity and inclusion. With a background in HR management, Karen's focus has always been people, which is the key asset of the NHS. More recently, Karen has become involved within the equality and diversity agenda, supporting the Trust to develop and deliver its legal and ethical objectives using national frameworks, including EDS2, the Stonewall Workplace Equality Index, WRES, WDES, and Disability Confident to benchmark and measure progress. Her passion and dedication have helped influence positive change across many diverse work streams. Her ambition is for Newcastle hospitals to be at the forefront of the equality and inclusion agenda. Hi, Karen.
Hi. I think Paul's just given away that he's older than me as well by the 30 years. I think I'm probably 20. Hello.
And last but by no means least, I'm going to introduce Dr. Leanne Armitage. Dr. Leanne currently works as a junior doctor with interests in anaesthetics. In 2018, she co-founded a charity called the Armitage Foundation, which exists to increase diversity across UK medical schools. As a result of that work, that she's been doing with the Armitage Foundation, she was awarded the 2018 UK Queen's Young Leaders Award by Her Majesty the Queen at Buckingham Palace. Leanne has also featured in the 2021 edition of the Future Leaders magazine as number 4 out of 150 of the UK's most outstanding African Caribbean students and new graduates. And in 2020, she was named a LinkedIn top voice and has featured on several news channels. Good morning, Leanne.
Good morning, everyone. Very happy to be here.
I mean, I'm sure you'll agree that that's a really esteemed panel, and I'm sure it's going to be a really rich and fruitful discussion today. But before we begin, I'm just going to give a little bit of context about today's webinar. The 2021 NHS Staff Survey found that nationally, around 18% of employees had experienced harassment or bullying by a manager or colleague. That's 18% of over 600,000 survey respondents, which roughly equals to 108,000 people. That's 108,000 people within the same organisation experiencing completely unacceptable behaviour. Now, another alarming point about this is that those statistics have stayed about the same and around 18% across the last 4 years of NHS staff surveys. And not to forget that 18% only takes into account those who disclosed that in the survey, which in our experience as Culture Shift is only ever the real tip of the iceberg, because not only do more people stay silent about their experiences, but people are often concerned to share their true experiences in a survey because they don't believe in its true anonymity. It's one thing to uncover the problem, but the real challenge is definitely finding effective ways to tackle these issues within the NHS. And that's what we're going to be discussing today. So my first question to the panel is that the dial on bullying, in the NHS staff survey hasn't shifted from that number of 18%. Why do you think this is? And I'm going to come to Juliana first.
Thank you. Good morning again, all. I think there's loads of different reasons. I think over time, especially using large umbrella categories for different groups of people, not just race, but also disabilities. We have forces in small elements of these groups, or some of these groups who aren't heard, some, as you mentioned, with the staff survey and the percentages, it's only those who have disclosed as well, which is a small amount. So I think over time we've missed the opportunity of disaggregating to find root causes. I'll leave it as that for now. I know some others have some comments.
Yeah, definitely. Paul, I'd like to come to you next.
Yeah, no, I think Juliana's absolutely right, actually. And your introduction was spot on, Gemma, when you identified what the problem is. And in fact, we have identified the problem. We know what the problem is. Like you say, it's been persistent. Every staff survey report since it was introduced, which was probably about 10, 15 years ago, really, has identified bullying and harassment as a problem. And then, ironically, only today, you've got to look at the headlines on the BBC News, and there's a new report, another report, you could say. So the Messenger report is going to be published today, which we talked briefly about earlier. And what's the headline? Yeah, leadership are being bullied. So, I mean, there's a bullying culture from the top to the bottom within the NHS. It's as simple as that. And Juliana made a particularly pertinent point, which is about disaggregation. Because if you disaggregate that number that you identified, it's about 18% or so, if you then look at that in relation to disability, so disabled staff versus non-disabled staff, the figure is even higher. around disability. If you look at it in relation to ethnicity, you look at the comparison of experiences from black staff to white staff, again, it's much, much higher than that 18%. And you can do that on every protected characteristic: sexual orientation, age, and religion as well, which we don't look at very often. But if you look at it around religion as well, you'll find similar patterns. So we've got the data, we've got the information, we know what the problem is, we know that it's worse for particular groups. We need to do something about it.
And in our work, we work a lot with within the education sector at Culture Shift, and prevalence in that sector too is something that just we kind of get stuck on. We keep proving that there's an issue through these surveys and through these reports, but very, little is done to go, okay, we know that that is an issue. Here are the things that we are going to do to tackle it. And I think too few organisations are brave enough to share, this is what we've done and it appeared to work, and shift that dial, but also what hasn't worked, and therefore please learn from our experience because we tried this and it didn't work. So please, don't do that. Let's discuss how we can do it a different way. Karen, I don't know whether you've got anything to add to that.
Yeah, I was just going to say a bit like what you've just said. I think we need to focus on solutions, because we have, there's legislation covers this. Every organisation has policies and procedures in place that say, you shouldn't do X, Y, Z, yet it still happens. We've got 18,000 staff at Newcastle, and in terms of employee relations events, we get very few bullying and harassment reported, but we do have I suppose an increase when we look at the staff survey, and we're in quite a good position, because overall, until you start to disaggregate it and break it down and look at different protected characteristics, we're in the top 20%, I think, overall for bullying and harassment. But when we look at BME staff, that drops. But I think in terms of solutions, the biggest problem, it's about communication, isn't it? And I think the biggest problem is for people to raise awareness and to have a voice and feel like they're going to be heard. You have to have a number of things in place, and one of the most important things is a culture of psychological safety. And when things are brought to a manager's attention, that they do something about it, and it's something constructive and confidentiality is maintained. These are all of the issues we hear through the staff networks. And of course, managers are under a lot of pressure at the moment to, as they are always in the NHS, to deliver efficiencies and motivate staff. And sometimes I think when a problem arises, if a manager doesn't feel it's a significant problem, and we've got to remember, if a member of staff's brought it to the manager, it is significant to them, that we don't just look for a quick solution, and actually it's managed and investigated and it's deemed appropriate. Otherwise, what you do is you stop people. You silence them, because who's going to bring a problem if nothing's ever going to change? So it's around, for me, we've got the problem, we've known we've had the problem for years. We really need to focus on how we create the safety and the organisational culture that allows people to, one, bring the query forward, two, be heard, and three, for something to happen about it. And I think that's where, if I was to say what the problem in the NHS is, that's what I would say is the problem, that people don't raise it, because when they have raised it, nothing has happened.
Absolutely. And I'll come to Leanne in a moment, but in our experience with working with some NHS organisations, there's been an inconsistency on that kind of response across the organisation. So depending on who you told would depend on the response type that you would have, and the length of time it would take for someone to get back to you and acknowledge that issue. And I think consistency needs to be brought across organisations as well, so that no matter who you speak to within your organisation, you get a consistent response and a consistent signposting to support and what should happen next, because that breeds problems as well. If someone, say someone experiences something, they do decide to speak up and tell someone, then they don't hear anything for 12 weeks. Someone else says, I've experienced that problem, and they say, well, don't bother speaking up about it because nothing happens. It goes into the abyss. And we have to get that that service level agreement between our people, so that there's a consistency in what happens when, in response to issues. Leanne, I know you wanted to come in and add something.
Thank you, Gemma. I agree with what everybody has said. And I think in order to really see change, you need to approach the issue from a structural level and at an individual level. And I think simply it can start as well by really having clear definitions of what bullying and harassment actually is. Because I feel like many people are experiencing it, but they may not even speak up or know to speak up because they don't realize that that's actually what they're going through. So then there's not a real reflection of how big the issue actually is. And I think if there was more focus on that as well, it would really highlight that this is something that really needs to be addressed and more attention needs to be focused on it. I think also what people have discussed about there being a culture change. I think in the NHS, it's still very much hierarchical in structure, and there are still balances of power that can be quite challenging, in that if somebody is experiencing bullying and harassment by a senior, oftentimes they may be quite scared to really speak up about that or try to challenge that because they're worried about their career progression. And we already have highlighted that certain individuals, especially people from a Black and minority ethnic background, report higher rates. And if you look at international medical trainees, when they come to the UK, sometimes they have very limited support system here because they may have no family or not really know any doctors. And so if they're experiencing bullying and harassment, being able to feel comfortable and confident to really speak up can be very terrifying for people who are coming from those kind of backgrounds. And I think it's really important that our NHS leaders have an awareness and understanding about this. And I know that speaking about racism and other topics and bullying and harassment can be quite uncomfortable, but I think it's really important that our leaders recognize who are these vulnerable groups and they have informal conversations with these doctors or nurses or NHS staff and make them feel comfortable to be able to know that if you're having an issue, you can come and speak to me. So I think there are so many different things, but those are the things that I'll share for now.
Yeah, I think they're all, like incredibly good points. And, we keep sort of talking about psychological safety, but I do want to go back to that point that you made about consistency in definitions. One of the biggest things and trends that we see on our software is people trying to define what it is that they've experienced, because someone can feel really uncomfortable about something, but not necessarily use the word bullying or discrimination because they feel big words, right? And they feel uncomfortable. They want to raise it, but they don't know how, and they don't know how to define it. And I think as an organization, we need to make it easier for them to label those experiences so that it can connect to support for what they've experienced. Juliana, I know you wanted to add something.
Yeah, so I work for East London NHS Trust, which has London services, but also services outside of London. So although the best thing is to standardise a process, especially in timelines and responses, we understand that not one size fits all or not one solution will fit everyone. So we do try and work around that and ensure when we have solutions that are at service level or directorate level and meet the needs of not just the community, but the staff there. Additionally, I wanted to add, in terms of making the processes easier for people, what I have found is that a lot of people will try and report a personal grievance under the whistleblowing policy, and making it clear at the very beginning of that policy that actually this is not what that policy is for. There is another policy to support you, because if they go too far back,
yeah, your connection cut out
a little. Realize, oh, well, it's the wrong policy, no one's going to support me. Sorry.
Gemma,
so my connection cut out, sorry.
Your connection cut out then, but it was a really important point that I think people are hitting that kind of whistleblowing button, or, accessing, the Freedom to Speak Up Guardian network, because they don't know kind of what else to do. And they feel like that's their last chance saloon. And they know that something probably will happen if they access whistleblowing, because we talk about it, all of the time. And if we're going to prevention is better than cure, right? I don't need to, you know, say that to everyone on this call, but early intervention and intervening, and the word escapes me at the moment, but that early intervention piece is really important, because if someone feels like they've got nothing left to do other than whistleblow, which is the, you know, the wrong policy, and they don't really care that that's not the right policy, they just want help, right? We've got to look at that early stage intervention, definitely. Karen, did you want to
Yeah, can I just add one more? It was with my HR hat on, because sometimes with this, formal processes don't help, because what it does is create sides. And I think often with bullying and harassment in particular, because things, you know, people know generally what they're allowed to do and what they're not allowed to do, so it forms subtleties, and those subtleties are really, really hard with an HR hat on to evidence in the workplace. So I think it's also about being aware of that. It's looking at, maybe it's not always diving straight into formal processes and using talking mediation, but it's also you know, raising awareness within the HR teams that with this particular subject, you're not necessarily going to find definitive evidence, and it's not around prove or disprove, it's around the balance of probability. So it's being mindful of all of those things, because again, like I said before, if people raise an issue and it never goes anywhere, or it's formally investigated and the outcome's never in the individual's favour, that stops people making formal claims as well. But I think informal, when I've dealt with things like this, I've always found that the best way to deal with them, if you can, is on an informal basis, because it's a win-win for everyone, and you maintain the interpersonal relationship that's so important at work. Sometimes you can't, but if you can, that's the best way to proceed, I've always found.
I would agree that when it goes to that formal situation, it's very difficult to come back from that, and someone is someone's leaving the organization, or someone is being moved departments, you know, in that kind of scenario, I think. And like someone's made a point in the comments, that when it goes formal, there are winners and losers, and that's not really what we want to achieve. We want to achieve a positive working environment where people feel safe and secure in what they're doing and saying and how they're behaving, and for people to carry on in their work in a positive environment. Paul, I know you wanted to share an experience.
Yeah, so it sort of goes back to what you were talking about a little bit earlier, Gemma, but it's sort of this happened. This was my experience of about 20 years ago, which sounds a long time ago, and it was, I'm afraid, but it very much resonates with the Messenger review that I mentioned earlier that's been published today. So my first job when I came into the NHS was as a HR director. And I went onto the board of a general hospital in England. I won't name the trust. And about 8,000 staff, so it's a relatively big organisation. But I was only there 2 years. But the second year of me being there was the worst year of my life, because I was terribly bullied I was reporting into the director of nursing at the hospital. And I was really, really badly bullied, completely undermined, you know, every day almost, not included in things, explicitly excluded from things. You know, it's that those behaviours that are so damaging, I think. And this was obviously at quite a senior level. So I spent a year of my life going through that. Eventually, I did raise a grievance. So I went so Eve was the one in the chat box talking about formal procedures, and what Karen was talking about as well. So I did raise a formal grievance, but the chief executive just couldn't deal with it. He just wouldn't deal with it for whatever reason. I ended up getting seconded out of the organisation. And this is a behaviour that I've seen replicated and still gets replicated, certainly at senior levels within the NHS. Problems just get moved on and passed around, and they don't get addressed. So I will always draw on that experience, and I will always remember those behaviours. And we've got to remember as well that culture is essentially, you'll know this, Gemma, but culture is essentially a collection of behaviours. Mm-hmm. That's what it is. Yeah, the behaviours of your staff, the behaviours of your managers, the behaviours of your leaders are the culture of your organisation. And we need to remember that. And if we're going to change it, we've got to change those behaviours.
Definitely. Well, thank you for sharing that experience, and I'm sorry that that happened, but I really appreciate you sharing it with us today. We have talked a lot about the fact that the issue exists. I'd really like to kind of move on, if we can, to potential ways of tackling that culture. And I know that there is a lot of focus around civility and respect within NHS England. And I'd really like to come to you, Karen, if that's okay, to talk about maybe some practical steps that you're implementing within your organisation to try and reduce micro incivilities.
Yeah, we've got a number of things. We've actually got a trust breakthrough objective this year around improving staff survey responses in relation to bullying and harassment, and particularly our ethnic minority staff. So that's an organisational high level objective. So it kind of raises the profile within the organisation of it. In terms of BME staff in particular, we've recently held a Let's Talk Race event, which was an hour-long session with a number of national speakers, but we really focused on all of the questions I get asked as head of EDI, why focus on one protected characteristic, or, all the different things you get asked. We're also looking at, because in Newcastle, in terms of BME staff, we've had I would rag rate us since workforce race equality came in as red in relation to that. So although we're in a very good position when we look at all staff, when we look at certain groups of staff, we're not. So we've started a quality improvement program. In fact, it starts this week, looking around res and behaviour in particular, and we're going to be applying quality improvement methodology to try and approach the problem differently. So our, we've got DMs involved, we've got Associate Director of Nursing involved, we've got one of the medical directors who has responsibility for health inequalities involved, our team in the BME staff network. We've also looked at reverse mentoring within the trust. So we got the exec team and many of the senior leaders. We had 52 members of staff participate in that. And although people said they didn't particularly learn anything new, they understood the acuteness of it. So it raised the profile and it raised the, what people deal with on a daily basis. There was a lack of understanding of how it can affect people. We've also delivered microaggression training in all of the directorates within the trust. It's a small number of staff, considering we're 18,000 staff, we've only hit around 300 people, so it's not had a massive impact, but we've delivered that in every directorate, and for participation on the course that they had to commit to rolling additional work when we call upon them in their directorate, because it's one of the things we see as a really big issue within the organisation and something we need to fix. In our staff network, all of our staff networks were involved in that, and the organisation we used real examples, because often if you can make it real to the organisation, it has a little bit more impact. Mm-hmm. Our staff network developed a video on our video resource on microaggressions. We've got 2 members of staff who are doing project work at the moment in nursing, so not my team, but my team's been heavily involved in it, and we've created 3 resources, 2 of which are around microaggressions, around explaining what they are, but how to manage them, how to respond to them, what to do if you're in any one of the positions, that, covering, if you're the person who it's aimed at, if you're the person who hears it, if you're the person who's confronted about saying something. So we've tried to raise awareness and understanding in relation to that. They're in final process. They haven't gone out yet, but we've also looked at, we've published data as well. So we a couple of years ago, I think 3 years ago now, we did an ethnicity pay gap report, not quite like the gender pay gap report, but we looked at nursing, medical, and we looked at very senior managers, and we looked at a number of things around pay, but we also looked at behaviours. And we, and some of the things that are in that report don't put us in particularly good light in terms of some of the comments, but our chief executive shared that internally, she shared it externally. We didn't hide behind it, so we were very open and transparent about needing to improve and do better. And the other thing that we've done very, very recently is implement an equality dashboard. So every directorate, as part of their performance review, so it follows in with the governance processes, get what I call an equality dashboard, and that covers 5 protected characteristics. It covers a range of things, loosely, very loosely associated with the metrics of the Workforce Race Equality Standard. But what that does is quarterly ensures that the Directorate knows their equality data. It doesn't cover bullying and harassment in particular, because we haven't found a way yet to kind of get the information into the dashboard in a way that we can, you know, at a push of a button, roll it out. But what it does do is it allows for that conversation to be brought in, because we're talking about equality issues, we're talking about leadership, we're talking about representation in their directorate, and we can also bring the staff survey information in, because each of the HR heads, there's a number of HR heads, they comment on that dashboard and start the conversation and ensure the conversation is taking place. And as I say, that's only just happened since January, but the aim behind that is if every directorate knows their info, you know, I often get told, well, Karen, what are you going to do to fix it? And I'm thinking there's 18,000 staff, you know, what are you going to do to fix it? I can do that in my team, but what do you do in your team? So this is a way to give data, autonomy and ownership to the directorates. And, you know, if we have incremental changes within every directorate, overall within the trust, that will lead to, hopefully, a positive outcome. But I think the thing that I'm hoping will make a difference is the res improvement program, where we're just going to apply a methodology and tried and tested, and try and link it to this particular problem. And because we're so big, we'll probably pilot it in 2 or 3 areas, and we've got data to say which areas are maybe not as good as others. And hopefully within the next 12 months we'll be able to show some improvements, but we've had a rethink, because we've done an awful lot over the last 5 years, and as you say, it hasn't changed our position. So the res improvement program is a way to, I suppose, try and look at the problem differently, apply science, and see if we can work through it in a methodical way and come to a positive solution at the end of it.
Yeah, and I think there's something that you raised there about your chief exec sharing the sort of warts and all data, if you like, both internally and externally. And I think that is so important that we do that. We are bold and we do that more, because, you know, it's one thing for the kind of National Staff Survey to be published every year. And what I hear across different organizations is, yes, but other organizations were worse, or nationally it was only this, so we're not that bad in comparison. And we're sort of like competing with the, like, you know, or excusing that kind of like, well, the bar was set there and we're not that far away from the bar, so let's not worry about it. That's not going to change things. And I think with organizations that Culture Shift work with, what the best organizations do is close that feedback loop regularly. So they publish the trend data, such as number of bullying reports, who experienced those incidents, what happened as a result of those reports being raised. And then they also publish their action plan about what they're going to do in the next quarter. And that is a constant feedback loop, which is encouraging that speak up culture to say, if you report something will be done about it, because look at all of these actions that are being taken. And some organizations are getting great at saying these are the incident types that are happening, but it's that action plan at the end of it that means that, like, change is being made. So it's worth saying something if you've experienced something, because then you can see that that culture change happening. We've got loads of questions to get onto, so I was going to address that question to the whole panel, but I'm going to move on to some specific questions that I want to ask each of you. Leanne, the BMA found that more than 75% of ethnic minority doctors experience racism more than once in the last 2 years, while 17.4% said they regularly face racism at work. And you work really closely with doctors from an ethnic marginalised background at the Armitage Foundation, because you've got that focus on increasing diversity across UK medical schools. So what do you think needs to change within the NHS when it comes to doctors experiencing that racism regularly?
Thank you, Gemma. So just to clarify, with the Armitage Foundation, we're working with students who want to get into medicine. So it's mainly with school students to increase diversity across UK medical schools. But as a junior doctor, I've definitely worked alongside other medics, and I've also been involved with the BMA, their BAME steering group, which is addressing the issues that BAME doctors face. I think similar to kind of what I was mentioning earlier, I think it's really important that we create environments and spaces where these issues are discussed, because I think the reality is some people still may not even think racism is an issue, especially if you're somebody who's never experienced it. It's just not something that you really think about. But there are many doctors who are coming from BAME backgrounds who are experiencing these challenges. So I think creating environments where people feel comfortable to be able to raise these concerns, and where they feel like their concerns are actually being taken seriously, because as we've already discussed before as well, I think many people fear that even if they do raise a concern, nothing is really going to happen to change it. And also what was mentioned about the reporting processes being so long-winded. And if you're going through something which is really quite emotive, as we've already discussed, these kind of issues affect people's mental health, and you know that it's going to be a long, drawn-out process, and you're worried about how that may affect your career progression, because it's well known as well that diversity decreases the more people progress. There's not much diversity in consultancy and at board levels within the NHS. And so people who are coming from BAME backgrounds may also be very worried about how, if they do raise issues, how is that going to affect their career progression? And, if some of these seniors are the people signing them off so that they can continue progressing, there's all of these other factors that need to be considered. And I think it's really, some of the interventions, I think they're so simple, but they're just not being done. And as we've already discussed, there's so much variation depending on different NHS trusts, but having somebody that is a safe person that you can go to, who will be accountable and who will really address some of the issues that you're raising, I think that is also an important intervention that needs to be done.
Yeah, definitely. I really agree with that. Juliana, I want to come to you now. As I've kind of alluded to and mentioned, at Culture Shift, we really advocate for using data, but more specific disaggregated data to inform quality improvement projects. And the data that we connect through our anonymous reporting platform allows organisations to identify those worrying trends and who is experiencing them. We know that you use data, specifically, obviously, the staff survey, but you've mentioned before that disaggregation of the data is missing in the staff survey. So how can we change this?
I think there's a lot of things that we can do internally at local levels to improve how we interpret staff survey data. So for instance, I've worked on a lot of health equity audits that look at patients who experience barriers to care, and we go beyond the protected characteristics and deeper into them, but also looking at, I know you've heard of Core 20+5 and such, but also looking at areas of deprivation. And so we're looking at where these workforce, so we know in East London, I believe it's over 20% of our workforce live in the boroughs that we cater for, and looking at where staff also live in deprived areas, looking at how that might affect their pay bands, the pay gap and such, and also looking at, I want to say interdependencies, but we can say intersectionality. We do that a lot throughout everything else. But I mean, when we're looking at discrimination in disabilities, we're looking at discrimination amongst different types of disabilities as well. It's not always us versus them in terms of splitting up those who have and those who do not, especially when you look at those who have it at varying different degrees and levels, and it impacts them in different ways. So I guess at a local level, there's a lot to look at, and also ensuring that we're no longer just comparing everything to the wider demographic or the wider wider population, it has to be very reflective on the population that we're catering for. So if we have a large population of a certain South Indian community accessing a certain service, then it makes sense to have appropriate representation of that ethnicity working on that workforce in that area. So we're looking deeper at the data and who is experiencing bullying, harassment, or other barriers in terms of the workforce, but how it also relates to the demographic and the patients they serve.
Yeah, I think that's really, it's a really interesting new point there about representation in terms of, so what we see a lot is that we know when you add different intersectional characteristics, the likelihood that people with many intersectional characteristics experience bullying, harassment and discrimination goes up. But we often see those people completely missing in the data, which means they don't feel safe to speak up. And I think that's a really important point to address, because if those people are the ones that are experiencing this disproportionately, we need to make it incredibly safe for people to access support and be able to speak up when they've experienced something. So that a lot of work needs to be put on that side of things to make it super safe for people to be able to flag when they are experiencing an issue. Paul, I'm going to come to you now. The NHS People Plan has a very specific pillar around belonging in the NHS. What do you think needs to be the biggest focus for organisations as a whole to improve employees' sense of belonging?
I think one of the first things we've got to do is, it sounds a bit basic, but it picks up a bit on Leanne's point I think she was making earlier, which is around definitions. We've got to understand what belonging is. You know, I think the evolution of equality, diversity and inclusion language is quite interesting when you look back on it. So we started off with this concept of equality. We then started talking about diversity. We then started to talk about inclusion. We then started to talk about equity, and I don't think anybody still understands what equity means. So I think there's something to be done there. And now we're starting to talk about this language of belonging. You know, and it's good to see the language evolving, and it needs to evolve and it needs to change. And I'm a big advocate for that. I mean, at the moment, I'm making a big play about putting pressure on the government to review the Equality Act, because the Equality Act was published in 2010. It's the primary piece of equality legislation in this country. It's 12 years out of date, and it's completely antiquated when it comes to some of the language that we're using now in this area. So we need to understand, I think, Gemma, what belonging is, and we need to define that. And I think that's the role of myself, Leanne, Juliana and Karen. That's one of our purposes to do that. And I think it's well defined actually within the NHS People Plan. And we can't, and the other thing we've got to not forget is, just picking up on what Juliana was just talking about, you know, the NHS is the 5th largest employer in the world, with by far the largest employer in the UK, 1.4 million staff. You know, we are a microcosm of UK culture as an organisation. Yeah, it's a huge responsibility for us, you know, and we mustn't forget that. You know, Juliana's right to talk about the demographics of locals. And in that respect, people do need to look at their own communities. Yeah, it will differ. So the solutions for Juliana in East London will be very different, for example, I travelled recently up to Lincolnshire, which is a very different place. It's a very different culture, very different demographic, but they have got issues. They've got, in terms of ethnicity and culture, they've got a very strong Eastern European community up there, for example. But, you know, their big issue probably is more around, you know, urban deprivation and those types of things, urban inequality, or rural inequality rather, and also issues around disability as well, because of the aging population in that particular area. So you've got to find your own solutions that are pertinent to your own community and your own situation.
Yeah, I think that's such an important point. Like it really is fundamental, because that blanket approach across like the NHS across the UK or NHS England is just not going to work if we use that kind of those broad brush strokes. I am going to come to some audience questions, but there's loads of other questions that I wanted to put to you all, but the time is going so quickly. Where is the time going? So this question says, Gemma, can we talk about the upstream preventative measures and growing a genuine culture of zero tolerance beyond the language? Which I think is a really interesting question, because my own perspective on zero tolerance is that I feel like it is a unattainable promise, zero tolerance, because zero tolerance to me, and what I would expect if I'd experienced behaviour that I had been hurt by, is different maybe to organisational like zero tolerance and what can and can't be done just legally. And I think for organisations to promise zero tolerance will ultimately cause problems, because it's something that it's not a promise that we can keep. I don't know whether anyone else has got anything they want to add to that, or how we can try and go towards an organisational culture where people are held accountable for their actions rather than complete zero tolerance.
It's really difficult, because zero tolerance generally to staff means you're disciplined and you're dismissed, and that's not always possible depending on the circumstances, and it kind of goes again, you're back to the someone wins and someone loses, and actually education piece I think is as important. So it is difficult. I mean, I've been in situations where I was involved in a grievance, and it was around a disciplinary outcome, and they're confidential. So again, that's difficult as well, because the person who raises the complaint doesn't usually get to know the outcome. They have a voice, but they see a person walking around, so they know they haven't been dismissed. And it is difficult. But I think again, I would always advocate if you can. A win-win approach. Obviously there's cases where actually dismissal is the right thing and it's right, but what we generally find is it's subtleties, and sometimes it's people, sometimes it's people who know exactly what they're doing, and sometimes it's not. Sometimes it's because people haven't lived in the same experience, they don't have the same life experiences, whether that be around a protected characteristic or social deprivation, and they don't understand. And it's around educating everyone to understand and be mindful of what they're saying. Most people, not everyone, but most people don't set out to hurt people. And therefore that's why I think the education piece is important. I think when you're at a disciplinary, that's a little bit different, because often it's perhaps a more significant issue, and there's some things that really can't be tolerated. But where different people have different perceptions around what zero tolerance means and at what point it applies. Yeah. And
someone said in the chat that zero tolerance is entirely subjective, and that kind of is the underlying issue, that as an organisation, to make that promise to your people, you shouldn't be making promises to your people that are
and it backfires if you don't do what people expect, and then people withdraw and think, well, nothing ever changes. So.
Exactly, and that's not, because that damages trust. Paul, did you want to come in there?
Yeah, I just wanted to really endorse what Karen's saying, and it is about education. I think we've got ourselves into a bit of a corner with bullying and harassment, because we use that phrase and we've used it for so long that it's almost become, people use it and don't really understand what it means. So we do have to educate people. We do have to remind people that whilst we can, as Karen said, aspire to a win-win situation, unfortunately the world's not like that. It doesn't always work out that way. So we've got to try and find different solutions, but at the same time we've also got to be very, very clear about what type of organisation we want. And I don't think we do enough about raising people's awareness around bullying and harassment. I think there's a lot more that we could do in terms of physical. I'm always impressed when I go on the London Underground and Tube in London. You know, the posters are everywhere saying that, you know, bullying or harassment of our staff will not be accepted and is not acceptable. And, you know, I don't see that when I walk into a hospital. I see lots of posters about diabetes and cancer, and which is right, they should be there as well. But I don't often see posters or even screens showing messages about, you know, that sort of thing. I think we could do a lot more to convey. Yeah.
It's interesting that you say that. I was sent a picture of a poster in a hospital the other day. My friends love to WhatsApp me these things. And it said, we have a zero tolerance approach to bullying and harassment of our staff. If you bully and harass our staff, one, you'll be asked to stop doing it. And there was a whole list of things to get to, like, I think it was number 6 on the list, will refuse care. Right. And I know to withdraw care is a very significant step. But there's steps 1, 2, 3, 4, and 5 that say to your staff, this is not, zero tolerance isn't accepted, because zero tolerance is stop as straight away, right? So that's what I mean when that promise is difficult to be kept, because just in that poster, which is like, on the one hand, great, you know, like advertising to people who are accessing care, don't bully, harass and discriminate against our staff, but it is saying, but steps 1 to 5 mean that you can really. Karen, did you want to add to that?
Yeah, it just there's a really good quote, and I can't remember where it come from, but it says a culture is defined by the worst behaviour tolerated, and I think, you know, no matter what your culture, if people are, I think key to this is, if you hear something, call it out, and you can call it out in a really appropriate reasonable way. And part of the film resource that I was mentioning before gives different models, and I can't remember them off the top of my head now, and it gives kind of different models to assist in doing that. So if you hear it, this is how you approach it, and this is how you raise it. And I think until, as organisations or the NHS, people within them, whether it's directed at them or not, because sometimes the person it's directed to doesn't feel able to do that, but you need to be an ally and actually call it out and do it in a respectful way. But if all of us took a responsibility to do that, you would soon start to change. You would raise awareness, educate, and start to raise awareness. And I think eventually, it takes time, but eventually instances would start to drop. But it kind of takes every single person in an organisation to have a commitment to do that. It does. And that links to the zero tolerance, because what you're saying is anything that's inappropriate, you'll do it in a professional way, in a learning way, but it takes management aren't always there, and management don't always call it out, but and sometimes they're the culprits, not, but and that links back again to the psychological safety. So it's a big loop.
It is, but having courageous bystanders across the organisation, and not just expecting the people experiencing the behaviour to be the ones that challenge it, is really vital, and it's something that we definitely need to work on. There's lots of questions coming through from the audience, so I'm going to come to another one. Now, I know obviously this webinar started at 10 o'clock and we're all busy people, so I don't necessarily expect you to have read Sajid Javid's full statement on the report that is due to be published today, but one of the quotes that has been highlighted in the Times today is that apparently Sajid Javid has said, "In my view, there are already too many working in roles focusing solely on diversity and inclusion." Given all that we've discussed here today, what do you all think about that? Because I would really challenge that. I don't think there are enough people like really focusing solely on diversity, inclusion across the NHS organisations. Paul?
Yeah, sorry, I don't want to not allow Juliana or Leanne to come in, but I would just echo what you've just said. Fundamentally, I would disagree with it, but there is a sort of a point to what you're saying, actually. And I think, because I was going to say earlier, one of the things we do need to do as professionals is we need to work much more closely with our organisational development colleagues, most of our organisations here will have organisational development teams, and they're doing some fantastic work. In fact, some of us might even work within organisational development teams, and they're doing some fantastic work in this area. So I do think there is a call or a need for us to think beyond diversity and inclusion and put it within the broader context of organisational change and organisational behaviour and organisational culture. So in that respect, I sort of agree with him, but I think, you know, a blunt statement like that is just not the right thing to put out. It's just going to get misinterpreted.
Yeah, definitely. Leanne, do you have anything to add to that?
Yeah, I think making a statement like that could be potentially harmful because it almost suggests that they're not needed when actually they are. And I think similar to Paul's point earlier about how the context being so important because different organizations have different demographics and different challenges. When you've got different people who are passionate and who are trying to make a difference, they often will be addressing a subsection or a part of the group of diverse people that needs to be addressed. But at the same time, I think there's a lot of power in collaboration, and you often can have more impact when you do collaborate and do join forces. So I think it's about synergizing and joining together where possible, but I do think it's valuable to have people rising up in different areas to support different people.
Definitely. Juliana, I don't know whether you've got anything to add.
Definitely reflects what they've both said. I think that there definitely isn't enough, and we do need more who are solely focused. Working at East London, which is extremely diverse, has so many equality projects. I think one of my key roles is to bring it all in back to the trust, streamline it with our governance and ensure that our work is measurable and having an impact. And I think one of the things that the NHS is doing in terms of putting a focus and a lot of trust getting EDI leads is so that we can streamline all of the efforts, and it's no longer just working for one small faction or one silo of the organisation.
Absolutely. We've come to the end of our, go on. No, so we're going.
No, I was just going to say the agenda is huge. And I think operationally, I mean, in our trust, we've got me and 2 other people, and we've got 18,000 staff, 31 directorates, and EDI impacts on, if you do it properly, EDI has to be truly embedded in every single decision that the organisation makes. And if I'm being honest, what we're doing is a lot of ad hoc things that are trying to make a difference, and we're trying to link up, but we're not operationally, we're not resourced enough to do that. And I think what Juliana said was really good, because you do have to bring it together. You have to have the ability to evaluate it, find out what's working, find out what's not, and ditch the stuff that's not working, and then share good practice. But I also think we need to get, like Leanne said, get better at working together. And one of the problems is different trusts are at different paces. So some trusts are further ahead than others, but I think it's also working better between the operational side in terms of the people on the ground in the trusts, but then also with NHS employers, NHS England. I think the links could be stronger there or different, but in terms of needing the people, I do think we need the people. I just know the scale of the task in my trust, and that will be replicated in every single trust across the country. And I would say operationally, we're probably under-resourced.
Yeah, I definitely agree. I'm really surprised that a blunt kind of throwaway quote has been made, you know, in that way, and I think it just sort of speaks to the fact of how much kind of work there still is to do to raise awareness, and like you said, Karen, to make everyone realise that equality, inclusion, diversity and belonging is everyone's role across the whole piece.
And it reinforces the message that many people who have protected characteristics, you have to fight harder than anybody else to do things. It reinforces the message that actually they're not as important as everybody else, and I think that's the wrong message. But it also links to the health inequality side, which again come to the fore 2 years ago with COVID, but it's been around for, you know, it's not new. And you've got the Race and Health Observatory that are doing all the work they're doing. It's a massive subject.
It really is. We have come to the end now, which I can't believe how quickly that time has gone. I just want to thank so much our panel today for such an interesting discussion. Thank you to Juliana Ansah, Paul Deemer, Karen Pearce and Dr. Leanne Armitage. My name's Gemma Mccall and I'm CEO and co-founder of Culture Shift. We will be hosting more of these discussions, so if you've enjoyed it, please share the recording that will be shared with you afterwards far and wide, because I'd love to continue these discussions and continue the momentum and raising awareness of these issues across the whole of the NHS. Thanks everyone so much, and I hope everyone has safe, positive and happy days.